Basically, the big thing is, remember, postpartum hemorrhage is one of the 3 leading causes for maternal death in the country. So it's a very important issue. We have a special collaborative right now we're doing with family medicine, Greg from the OR, that we're looking at the postpartum hemorrhage bundle that we have in place. I wanted to get through the rest of the slides from the CMQCC because we talked about all the background, but this was the practical section, looking at the meta-analysis and stuff of why the different things we're using are used. Actually, I'll be on double video. That'll be weird, but anyway, so so I don't get a lot of echo. I'm going to turn my microphone off. Okay, and actually, I'm just going to close this one down anyway. Although, can you guys hear me on my iPad? I think it gives better audio. You guys just shake your head. Can you hear me still? Okay, great. To get to that, yeah, so I'll turn off the mic. Is that better or worse? It's worse. So let me just close this off. Oh my. Jeez, oh Pete. Okay. So anyway, once again, we'll share screen. I'm sorry that technology, I'm usually pretty good with technology, but Zoom, once again. I'm going to share my screen with you guys. Can you see my screen now? I got to pull up my OneDrive and get my slides up because I was planning on doing it on my iPad, but of course it's not working. So, where's my OneDrive at now? Ugh. So basically what I was going to say is does everybody aware that we do have a postpartum hemorrhage cart? Are you aware of that? Yes. And on that cart, we actually do have the flow sheets and everything readily available. So that's good news. Basically, we were kind of looking at what the treatment was, and we'll do the slideshow from here, start from current slide. Okay. So the Cochrane Beta database looked at what's the best management for postpartum hemorrhage. And the bottom line is that it's really varied, and the problem where the studies were done completely different. But basically there was 4 studies of active management versus expected management, and this is what you basically learn in also. And we'll discuss what that basically means in active management. So basically the active management reduced the risk of bleeding, but could only be due to consistent use of uterotonics. So what they found was, despite other interventions, really it was the use of medication and the active management that actually led to the reduction of postpartum hemorrhage. So the increased rate, but once again, the problem with using the uterotonics there was actually an increased rate of hypertension, as we know from Methergin. We also know that there was a bigger return in hospital for postpartum bleeding after the patients went home for unclear reasons. So basically the decreased average blood volume of newborns in active management, and it could be due to the delayed cord clamping, so nobody's really sure. But there was no difference in either group in severe bleeding in low-risk women. And then they basically used what they call grade scores for primary outcomes in low-risk women. So as usual, they're basically come to the conclusion and say, sorry guys, see if that's Jen, okay, great. So basically they say additional new studies support these conclusions, so that weren't included in the original database from 2013. So what their conclusions were, and this is where our guidelines come from, is basically oxytocin infusion, cord clamping and cutting, controlled cord traction, and vigorous fundal massage, commonly referred to as active management of labor. And new data basically says that really only the oxytocin infusion is probably what's most effective. So confirmed that, and so the new studies basically confirmed oxytocin administration is the effective part of active management. So cord traction and all that does not really matter. Fundal massage prior to delivery of the uterus, all different things you see different attendings do. But the bottom line is what's the most important thing is giving them that oxytocin. The other thing that's not clear is, or it is clear actually, is giving oxytocin at the time of delivery has been shown to reduce your risk of postpartum hemorrhage. Now, people say, well, won't you get an entrapped placenta? Well, that's because I think in the past we gave oxytocin wide open, and we were given big boluses of oxytocin, which is not the way we do it now. And you know, even when the nurses give you the increased infusion, it's 500 mLs per hour or 9 units per hour. And that's been shown to be the most effective dose. So giving more than that doesn't do anything but increase some of your side effects. This is also good that in low-risk women, these were high-resource settings. What that means is you're in a hospital like ours where we have all the available Bakri balloons, interventional radiology, et cetera. But basically, it made a difference in the long run whether or not you had the resources available. Now, for delayed cord clamping, just for those people who say, well, if we delay cord clamp and we wait that 60 seconds, does that interfere with the active management of labor? And they said, no, once the baby's delivered, you still do your delayed cord clamping, but you do start the Pitocin once the baby's out. You don't have to wait until the actual cord is clamped, which is a little different than I do it. I'll be honest. I typically wait until the cord's clamped, but obviously I'm practicing old medicine. Once again, old medicine. And it's hard, as you know, there's biases that come into medicine. And if you guys haven't been to Beth McIntyre's fetal monitoring course, she brings up very good points from the standpoint of it's very hard for physicians to change what they do in practice because it's always worked for us. But once again, just because it worked for us doesn't mean that it's actually the best way to do it. So the current medication recommendations, and this is a different from what some of us necessarily remember, that this is 2.0 versus the 1.0 is what we were always using before is. For prevention, it's oxytocin 10 to 40 international units. So I'll just tell you for ours, it's 30 units and 500 mLs titrated to uterine tone, or if you don't have an IV, and you guys know this, 10 units given IM, okay? The other thing is if you're given treatment, it says rapid infusion of IV oxytocin 10 to 40 international units at greater than or equal to 500 mLs per hour titrated to response. But I can tell you that our hospital policy and what IU's policy is 500. So it's greater than or equal to, but they found that greater than doesn't really do anything more than just being equal to 500 mLs per hour, which is your 9 units per hour given. Now the question is, I had been a big proponent of, you know, always using Methergin as your second line agent, but there's now enough evidence that misoprostol is just as effective as long as it's given sublingually. It does say there orally, but I'll be honest, ours is going to say sublingually, and it's up to 1,000 micrograms, and you give it at one time. So you don't give it in divided doses. So 600 micrograms orally, 800 micrograms sublingually. Now the nurses complain if you try to give 1,000 sublingually, have you seen how big the pills are? So they're about the size of an aspirin, a full dose aspirin, and you got to shove 5 of those under your tongue. That doesn't work out really well, but 800 is not too bad because you can put 2 on each side of the tongue subbuccally. They don't like it, but it works better. And they're not recommending rectally or vaginally because of bleeding and expulsion before absorption. So I know we still see people, and I'm as guilty as anybody, giving it rectally. But the problem is that a lot of times they either poop it out or pass it out or drop it out before it's effectively absorbed, where if you give it sublingually, you know you're going to get the full dose. And then the last alternative And the nurses, you always see cringe, because how many of you guys have ever used Hemabate? We don't use it very often. This is your prostin F2 alpha. So sometimes you'll see it prostaglandin F2 alpha, but we just call it Hemabate. And what's the big problems with this? Basically, we get huge amount of diarrhea and you get huge amount of vomiting. So if you're going to give Hemabate, make sure you order your Imodium and make sure you have your Zofran and stuff ordered, because the nurses will not like you, but that doesn't matter. We don't want her to bleed to death. But that's why most people use that as a third or fourth agent, but it is very, very effective. But just remember, they're going to get large amount of diarrhea and a large amount of vomiting. When we used to use it a lot before we used Prostin E2 for terminations or basically stillbirths that we're trying to induce, we would actually pre-medicate them with Imodium and Zofran before we'd even give the dose to try to mitigate some of the side effects, although it's not really all that effective. They still just have a ton of diarrhea. So the California guidelines, basically, we've been through this before, but I'm going to run through it super quick. There's stage 1, 2, and 3 of hemorrhage. Remember, it's in a table. If you can't, I mean, nobody expects you to remember it like NRP, but basically you're above your 500 for a vaginal or greater than 1,000 for a C-section. Your heart rate's above 110. Your blood pressure can be low. Your O2 sat's less than 95%, and you are still bleeding. So then you'd want to activate your hemorrhage protocol and find the checklist. That's the verbal order you can give, is we're going to activate the OB hemorrhage protocol, and that allows the nurses to take verbal orders from you kind of inferred so that you can get those right away. And then remember, you want to get help, but the primary RN should stay at the bedside and they should be bringing the cart to you. You shouldn't be sending the nurse out, because she's going to stay with you. The other thing is once you start the protocol, they're really supposed to start a second IV line, and 16 gauge is optimal, but I don't know how many guys of you have seen a 16 gauge IV, but it is absolutely humongous. So most of the time we're just going to get a second 18 gauge. Also, they recommend you start a Foley with a urometer. I don't think we do that routinely, especially now that we're going against CODIs, but we have to have good urine output. And you want to call the blood bank and get them type and cross for 2 units. And that's something I think that we don't do enough, is we don't initiate that type and cross in case we need it. Because remember, you're crossing them for 2 units, but you're not ordering it. They'll put it on hold for you, but you can release it and they're not going to send it up. But once again, even when you're in stage 1, if they don't have a type and cross on the chart, you want to go ahead and get that. So at least we can do type specific blood if we need to, so we just don't have to use up O negative blood. And then you remember the big thing, and this last little ditty right here is huge, is they now want us to quantify, not estimate, blood loss on 100% of deliveries, even vaginal deliveries. So I don't know how you do that accurately with amniotic fluid and poop and everything else in your drape, but you want to try to quantify it as best you can. And that's the standard across the board. The hemorrhage toolkit recommends this. We actually have a nice card. It almost looks identical to this, honestly. And it has the flow sheets and everything on it. There's a refrigerator on it. So that's the nice thing is too. So it's got a refrigerator, it stays plugged in. It's by the crash cart. And you have everything you need on the cart, including a Bakri, including Curl-X, all kinds of stuff. It would be nice if we could do a walkthrough, but I recommend when you guys are on OB service, since it may affect you, just look at the cart real quick and it gives you a list of everything that's on the cart, but I can assure you everything's there. So we pretty much followed the standard guidelines, and this is basically what's in there. I heard somebody wanted to say something. Is there a comment? The only thing I don't think we have is this modified B. Lynch sutures necessarily on the cart, because for a lot of places, they take this into the OR as well. But if you've not seen B. Lynch technique, it's very interesting. You basically go through the vagina front to back, and you put a stitch over the fundus of the uterus on both sides, and you basically tie the uterus down. Some people call a sandwich maneuver. That's the modified B Lynch, or the sandwich maneuver, where you put a Curlex or you put the Bakri balloon inside the uterus, and then you put the B Lynch sutures over the uterus, and you basically squeeze the uterus between the Bakri and the uterus. I mean, you basically sandwich the uterus between the Bakri and the stitches, but that you can only do that if you open her up. And I think most of us at this point, if the Bakri doesn't work, what you guys have seen and what I recommend is we have very good interventional radiology here, which we're very spoiled. But what I would remind you is if it's after hours or if it's later and you're starting to get into a postpartum hemorrhage, it's always very nice to give the on-call doctor a heads up that you might be calling for an emergency uterine artery ligation. So at least they can be mobilizing the troops to get them ready. You know, they still have an hour response time. So even if you put in your Bakri and they're bleeding, you may have up to an hour before they can respond and get your embolization even started. And that's before start time. So I just remind you that you probably want to give them a heads up. And if you don't need them, you don't need them. But it's better to call them in and not need them, especially if you're up in the 1,000, 2,000 range. This is stage 2 hemorrhage, basically continued bleeding, and now we're less than 1,500, but there's vital sign instability. So we're still under 1,500 EBL, but we're now having unstable vitals. Once again, the checklist, I mean, most people like the checklist like this. So basically, you know, we're kind of going from mobilize, act, and think, but you want to go through the procedure. If it's a vaginal birth, are we sure we don't have a laceration? Is it a retained placenta? Do we have atony? Most of the time it's going to be atony, now you're starting to think of a balloon. If the above measures are unproductive, now we're looking at the selective embolization. If it's a C-section, that's where the B Lynch sutures come in. If it's a uterine inversion, which we've had 1 or 2 of those at C-section, thank goodness, not vaginally, you want to try to get anesthesia involved because you're going to have to revert the uterus, if you will. And then if it's an amniotic fluid embolus, you're pretty much hosed, but hopefully it's not that. So what you want to do is you want to have the primary nurse, we'll call the obstetrician. So this is basically the flow sheet that the nursing staff and everybody's to follow. They'll call the anesthesiologist, and then they'll activate the response team, and that's the OB emergency button on L&D. Also, the big question is do you mobilize the rapid transfusion protocol or massive transfusion protocol at this point? That's really up to your call. As residents, I would say probably the attending's call, but definitely by stage 3, you would do the massive transfusion protocol. This is another thing that I think is different, is that additional uterotonic medications, you can always give Hemabate again. You can give misoprostol if you haven't already given it. And remember, you can repeat Hemabate 3 times every 20 minutes. A lot of times we don't even give 1 dose, so you can repeat that 3 times. And then you still have your IV oxytocin running. Bimanual massage, once again, if it's atony, but then if it's not atony and your uterus is like a rock, we've had 2 cervical lacerations and 1 high vaginal laceration that occurred basically thinking it was atony, and it wasn't until we took them back to the OR that we actually saw that we were having vaginal wall or cervical lacerations. So don't exclude your lacerations because they can bleed a lot. The other thing is you want to order your 2 units of packed red blood cells right away, and you want to order your stat labs, but you transfuse your blood based on your blood loss and clinical symptoms. So if their vitals are unstable, your labs are going to lag way behind. So don't wait for your CBC to see if you need to transfuse them. If you transfuse them and their hemoglobin winds up being 11 afterwards, that's fine because you transfuse them for vital signs and for patient. Once again, we don't treat labs, we treat the patient. Labs are a guideline. So if you know you've had 15 ml blood loss, you want to start transfusing, because remember, for colloid, it's a 1-to-1 blood loss, right? Or blood replacement. So if you lose 500 of blood and you replace it with 500 of colloid, you got a 1-to-1 replacement. But don't forget, it's a 3-to-1 replacement for crystalloid, so even normal saline. So people forget, if you lose 1,500 mLs of blood in order to replace their vascular volume, and that's if it all stays intravascular, you basically have to give them 4 to 5 liters of fluid just to replace what you lost. And obviously that leads into all other issues of third spacing, pulmonary edema. The other thing that you'll see us use in trauma, and we don't use it that much in OB, but for you guys who've been in the ER, we use a lot of head-of-starch just as a volume expander. And you can use head-of-starch in OB. We just don't use a lot of head-of-starch as they use in the ER, and I don't know why. Most of the time we're going straight to blood. But if you can't get blood up, if you're in some other facility, it's also, remember the reason you use head-of-starch, it's a 1-to-1 volume replacer. It's not going to help your oxygen carrying capacity, but it will stay in the system a lot better than if you give them just straight colloid. The other thing is you also find that people will want to give albumin, and I don't know how many rotations you've done on ICU, but it goes in waves as well. But a lot of times it's considered albumin will give you a lot of people who will go into ARDS. That's the thought. So I know for you guys who've done ICU recently, is albumin in or out now? Where are we at? Who's done ICU within the last year? I mean, are they using albumin still or not? No takers? Oh, okay. But I've seen them actually. I was in a ruptured ectopic case the other night. Last weekend I was on call, and she had 3 liters of blood in her belly, and anesthesia was giving her head-of-starch before we got the blood, just to try to volume replace her because she had quite a rapid, thready pulse. And when I looked in there, we had 3 liters of blood sitting in her belly, so it was pretty impressive. Sorry, the primary nurse wants to establish the second large bore IV, at least an 18 gauge. Then this is like a code situation, right? And I don't think we do a very good job of this, and that's why we're starting to do more mock hemorrhages. You want to be able to announce the vital signs so you know if you're heading in the wrong direction or not. The reason that's important is if you're heading in the wrong direction, then you may want to get up more blood and you want to call for more assistance, and you definitely want to be calling in interventional radiology, especially if you're continuing to give your uterotonics, sorry, and you're not getting any anywhere with that, especially if you put in the Bakri balloon and it's just running out of your Bakri balloon like a river. That's a very disheartening sign. The other thing that's nice about the Bakri balloon, though, is if you put the Bakri balloon in place and you're still having significant bleeding, then you strongly need to think about a cervical or vaginal laceration, obviously, because I've never seen a Bakri not slow down the bleeding significantly. It may still have a trickle, but unless you've had twins or triplets where the uterus is just extremely over distended, there's really no reason the Bakri shouldn't stop 95% of your bleeding, at least temporarily. And then once again, develop, you got to remember replacement therapy. Oops, sorry. Replacement therapy from the standpoint of you got to start remembering to replace some of your fibrinogen and some of your coag products, or you're going to dilute them out and get into dilutional DIC. We're very lucky, so we have blood available here all the time with the massive transfusion protocol and being a trauma center. But you really got to know your facility when you guys go out and practice to know how quick you can get blood, how much blood's available. Because like Brogan's told me before, he's had 2 units of blood in his hospital and that's it. And then the next blood's 2 hours away. So, you know, you got to be really aware of your surroundings, of what you've got available, because it's highly possible that you may not be, you get a certain level of comfort, I guess, if I would say that here, where at other places you may not necessarily have that luxury. And this is just something I think people lose sight of. A central line does not actually give you best access to fluid rehydration. It's the bigger the gauge and the shorter the catheter. Like if you put an introducer in for like a Swan-Ganz, you can, that's a 14 gauge, and you can dump in 300 mLs per minute. Remember, this is per minute. This isn't per hour. Think about that. That's 300 mLs per minute. You burn up a liter bag in 3 minutes. That's pretty impressive. When I was in trauma at Detroit Receiving, we had a rapid infuser, and with a 14 gauge flow cath in their groin, if they had a gunshot wound, we actually hung 3-liter bags on a carousel, kind of like they do in urology for when they're doing cystos. And it would basically dump a bag in. Well, look at it. You dump in a 3-liter bag in 6 minutes. I mean, that's pretty impressive, actually. So with a 14 gauge. Now, most of us are going to have an 18 gauge in, and you can still get in a liter in 4 minutes if you have a rapid infuser. And so rapid infusers basically put it under pressure and heat it. So it'll go in, it will keep the veins from constricting. I think that's part of the issue is when you put in cold fluid, you get vasoconstriction. So you're not able to infuse the blood as fast because one, you chill the tissue, and two, as it constricts down your blood vessels. The Bakri balloon, I don't know, hopefully you guys have all seen this, but basically it's just a big balloon that goes in intrauterine, and it basically holds pressure. The other key though is make sure they put in pressure to hold it down against the lower uterine segment. Once or twice I've come in and the balloon's just been floating. Most of your bleeding's coming from the lower uterine segment. That's the philosophy. So there's 2 ways to do that. You can either tape it to the leg, or you can actually hang a 1-liter bag of IV fluid to a tubing and throw it over the end of the bag and actually use that as like a gravity traction. But I'd say here, 99% of the time, I've never seen that done here. Most people just hold tension against it. And that's the key thing is when you're going in and checking on your bleeding, make sure that Bakri is still under tension, because sometimes the tape comes off, sometimes the uterus shifts, the patient shifts. And if there's a lot of play in that Bakri catheter that looks like the Foley down here, then you need to untape it and have it retaped so that you hold pressure against this lower uterine segment. Does that make sense? It's very inexpensive comparatively. It's very easy to use, and it's made just for this reason. Oh, that's really weird. Sorry, I don't know what happened there. Okay, that's better. Okay. Low-lying placenta, applications of the balloon. Basically, if you have a low-lying placenta, because they're at high risk for a accreta. So especially, remember, a low-lying placenta previous C-section, up to 40% risk in an anterior placenta being a accreta. Did you know that? So previous C-section, anterior placenta, low-lying or previa is up to a 40% risk for accreta. I mean, that's really high. That's almost half, right? Poorly contracting lower uterine segment, uterinatony. Once again, the placenta, accreta, and percreta, you're basically holding pressure against that site until you can get embolization. And then that may or may not save your uterus. The only other thing you can do for an accreta, or especially a percreta, where it's gone all the way through, right, is perforated through, is a hysterectomy. DIC at term or after second trimester loss. Obviously, the balloon's mechanical, so it's not using coagulation products. Therefore, it works well in combination with the compression suture for the sandwich technique. And then it also helps with vaginal sidewall lacerations if you put it in the vagina. But I don't know if anybody who's used that here for that. And it's easily placed when in stirrups. Most of us just put it in blind, let's face it. We will have them in the stirrups though. The question is, do you have to have a speculum? No, the cervix should be wide open, goes in, and then you just blow it up with the maximum, I think it's 600 or 900, and then you just pull tension down, and it's that simple. And that is a procedure that I think 99%, and Mel or Jen, you can comment on this, but I think that is a very simple procedure that is usually credentialed for all family physicians if you're going to do deliveries, whether you have C-section privileges or not, because it's a very, if you can put in an intracervical balloon, there's really no reason you can't put in a Bakri. And especially if you're like Brogan and you're out somewhere where you only have 2 units of blood and she's continuing to bleed, I put in a Bakri, pull down tension, and then transport her by helicopter as fast as you can get her out of your facility to be honest, because you got a problem. And that's the nice thing about the Bakri balloon is it gives you an opportunity to stabilize them enough for transport. Does that make sense? And it's basically got the least morbidity of any of the quote unquote next steps, because if your medication hasn't worked, what are you going to do next? Well, the Bakri is the simplest and easiest to do. And you can also be used as a tamponade test to temporize, determine the needs, and mobilize other resources. So basically, once again, if you've got a cervical or a vaginal laceration, this can help you determine what's what. Few issues for balloons. There are several other balloons available, but the only one in the US, and I'm sure Cook bought off the FDA, those bastards. No, I'm just kidding. I don't know why there's only the Cook balloon in the US, but basically the balloon is specifically designed for this purpose. It's a double lumen, silicone, non-latex uterine contour shape, good filling capacity, and it's very inexpensive. The other thing that's nice is about the tube down the middle, that's the double lumen, is that it allows you to see if you got bleeding above the balloon, because remember, if you have a really large uterus, you can have liters. And we did have that happen, unfortunately, where we had one of the Bakris clot up on me. And then when they took the Bakri out, there was like 3 liters of blood behind the Bakri. It was a disaster. She did well with interventional radiology, but she wound up getting like 6 units of blood. So that's the problem, okay? So always monitor your blood output. And then what I did with her, because, you know, I'm an ultrasound kind of guy, is I just put an ultrasound on her abdomen, then basically looked, and there was a big, huge clot above the Bakri, which then clotted off the Bakri, and it was just really not a very good issue. Oh, sorry, guys. And then basically what I did with her is I took her back for a DNC, because at that point I didn't know what else to do. And she didn't have, she had some, just so you know, if I take any patient who delivered back for a DNC, I'm going to find placental tissue. I don't care who you are, because they're looking for villi. They're going to find villi. There are rare cases where you got every single drop of placenta, but that's the exception, not the rule. So how much to fill? 150 to 500 is a big range. So there you go. Basically, you start with 250 to 300, unless the uterus is floppy. And there can be hourglassing of the balloon through a big dilated cervix. So just remember to make sure that it's kept up in the uterus. And if it does keep coming down, then you basically would use some uterine packing, okay? And then the B-Lynch sutures are kind of cool. You just basically 4 centimeters in from the same level on both sides. This is a 70 millimeter round-bodied hand needle. So you don't put it in with an instrument. It's 70 millimeters. That's 7 centimeters. So it's a big mother. And you basically just put it in. You go in, you see the direction that they're talking about. So you start on the right, you put it in, you come out the back. So you go in the lower segment, you come out in the back of the uterus, you bring it over the top, then you go back in the anterior segment, and then you go across, and it's basically like a big horizontal mattress suture, and then you tie the sucker down. Brogan actually said he's used it once, and it worked really, really well. And they recommend you do this with the C-section site open so that you can see it and place it and then close it afterwards. But you can see all the measurements there. And of course, unless you have C-section privileges, but it's more FYI. I've never done one. So I'd like to do one sometime, but I don't know. And this is what it looks like when it's done, which is interesting. Looks to me like a big, like ham loaf or something. Every obstetrician should know how to do this. Okay, I've never done one. Dr. LaPiccolo's never done one. I don't think Dr. Voss has ever done one, but apparently it's super easy. I think Brogan learned on a YouTube video, and I'm not even joking. He literally learned how to do it on a YouTube video. And it quicks because it takes less than 2 minutes to do. It's ideal at the time of C-section, obviously, and you can combine it with a Bakri. The other thing is that among 211 women, hysterectomy rate was 16% if it was done within an hour of delivery, but it was 42% with delay of 2 to 6 hours. So the bottom line is, and I think as they'll show, is you just want to have a very well-described plan in your own mind at your own institution, what your game plan is going to be. And if you're not accomplishing what you want to do at number one, then you go right to number two, to number three, etc. It's the delay between the steps that leads to the bigger, poor outcomes. So basically, massive transfusion protocol for stage 3, nearly 1-to-1 ratio of packed red blood cells and FFP. So what they're saying there is once you get up to more than 2 units of packed red blood cells, now at this point you're on your 3rd and 4th unit. You should give like 1 unit of blood for 1 unit of FFP, because you know they're going to be burning up their fibrinogen. And then also don't forget the platelets, and it comes up in the massive transfusion protocol. And then basically we're to our invasive surgical techniques. And basically a lot of this was described in the Afghanistani war and the Iraqi war. And this is for improving outcomes after big trauma, is that one of the reasons they weren't doing well is because we weren't replacing all the blood products. Part of the problem with blood and component therapy is you're missing a lot of the coagulation components, and we get so fixated on the red blood cells, we forget that it's very important to have platelets and fresh frozen available, especially if you want them to stop bleeding and not just continue to bleed and bleed. And this is basically what they said. The key was increase FFP to RBC ratio 1-to-1. And they started carrying packed red blood cells and FFPs even without their operating units, because that intervention alone, and remember it is therapy, so blood is therapy and blood is a transplant. So people who treat blood like it's not a big deal, it is a big deal, because it is a very vital element of survival, obviously. And then we know this 1 unit of platelets for every 4 to 6 units of packed red blood cells. I think the cheat sheet's in there as well. And then basically the coagulation triad, and we'll kind of end with this, is dilution, hypothermia, and acidosis. I don't know if you've ever seen now, but like in regular OR and stuff, they try to get everybody under a bear hugger or keep them warm. That's been shown to improve surgical outcomes. That's why we sweat our butts off in the ORs now, not just for the babies, but because it's been shown that having the temperature set higher does improve their outcomes. And that's what a bear hugger does, and why you also are supposed to use fluid warmers for the both rapid infusion and for the blood. And it doesn't become a big problem of dilution until you're 1 to 1.5 times the total blood volume replaced, but that would be, anywhere from 6 to 10 liters of blood. So it's not as much as you think. I mean, it's a lot, but it's not as much as you think. So start thinking about that as a dilutional effect. And that's why they came up with once you get past 2 units and you're in a massive bleeding protocol, it's very effective to do the 1-to-1 fresh frozen for one unit of that to every unit of packed red blood cells. And then acidemia, just like in the babies, once the tissue starts dying and you're hypoxic, then you're going to start releasing lactic acid, and lactic acidosis occurs. And this happens during massive transfusion protocols because of hypovolemia and peripheral tissue hypoxia. So, I mean, with massive hemorrhage, not transfusion protocol. So once you lose that significant amount of blood volume, now you start getting into tissue hypoxia. Tissue hypoxia leads to acidemia. Acidemia then leads, of course, to hydrogen oxygen ion concentrations that are a free radical. And basically, it's very difficult to reverse once you get into this kind of slippery pathway. So you do everything you can to prevent metabolic acidosis. And then this is stage 3. So basically, now you're at more than 1,500 ml, more than 2 units of packed red cells, and still have unstable vitals. You're basically notifying an advanced GYN surgeon, like a GYN oncologist. Here it would be me or one of the GYN surgeons. They were surprised when I told them we did our own cesarean hysterectomies here under emergencies, because downtown they're all done by GYN oncologists. So just to go to show you, there's a wide variation of practice even within the system. The charge nurse also should notify an adult interventionist interventionalist, and also an adult intensivist, because most of these are going to wind up in the ICU. And remember, it's better to take care of them in the ICU than to try to monitor them on our postpartum floor once they're stabilized. The team leader would basically, at this point, is when you activate the massive transfusion protocol. You also get a general surgeon comes with it, because obviously we have some kind of hemorrhage going on, and a lot of them are vascular surgeons. So they will come up and see if we need any assistance, especially if we're in the OR, which is really nice in case you need some help ligating the uterine arteries or the hypogastric arteries. Anesthesiologists, that's basically for them. That's all the labs. Primary nurse announces, once again, the vital signs and if they're changing, and by protocol, how often we're going to do them. And then the second nurse is basically given the meds and the blood, etc. And the third nurse is the recorder. And once again, you got to think of selective embolization, interventions that we haven't done yet, looking for a cervical laceration we may have missed, and then ultimately a uterine artery ligation or a hysterectomy. Okay, so basically, here we are again, just after the first, you can tell how important they think this is. They put it in red everywhere. Is after the first 2 units of packed red blood cells, use 1 unit of FFP for every unit of RBCs at that point. Okay. I think that's about it. So quantification is going to be very hard. Basically, we consistently underestimate blood loss, although for the last 4 surgeries, I've overestimated my surgery today, 900 EBL, 835 QBL. I think a lot of us are better than they give us credit for. The problem, as usual, and nothing against residents, but residents estimating blood loss is a lot different than a 30-year attending. Now they say that's bull, and that's fine. I'm not going to shrug the system, but basically we have to quantitate that blood loss on every single delivery now. Every case review of maternal death in California was basically reviewed, and we're doing that in Indiana as well. Studies show we get better with training, but the gains are partially lost over time. And that's why they came up, what that basically means in English is, yeah, we're really good at the stuff once we practice it and do it. But if you haven't had a postpartum hemorrhage for 2 or 3 years, which would be a great thing, and once again, it's a double-edged sword, right? We want to have no postpartum hemorrhages if we can help it, but by the same token, you don't get any practice. And that's kind of the concern there was up at Jay County doing deliveries. Not that they don't do a great job of deliveries, but the problem is when you're only doing 50 deliveries a year, some of the nurses haven't reviewed a strip for 6 months. And you can't stay proficient in anything if you're only doing it once a year. So basically, they're looking at different like simulations, and we're very lucky to have the simulator here and with Holly Jones, because everybody loves our simulations, even though we may laugh about it, etc. They are really good. The other one that's really, really good is, if you haven't seen your emails or the signs up, I think it's October 29th, I think, the group from Riley is going to come up and actually give us simulations, and one of them is postpartum hemorrhage, so that would be pretty good. Studies have shown that, once again, and this is not related to the experience of the provider, by the way, so you can be a 20-year experienced provider, and if you haven't used it forever, I'll be the first one to admit, I did my first ectopic for like 5 years, and I've done hundreds of ectopics, and I was rusty as heck because I haven't cut on an ectopic for over 5 years. Once again, denials makes delay, no denial, no delay. All right, and so under buttocks drapes, you know, in 300 mLs versus 900 mLs, you know, what else can I say? Try to take a best estimate. What you really should do is once the baby delivers, just like we do in the C-section, look at the suction container, you just look at your drape, see how bloody it is. If it's pretty clear, then you know, just like that last slide, you want to try to be able to say before she delivered the placenta and then after she delivered the placenta. And this is probably what I would call my EBL initially, but you think about it, that's got all the amniotic fluid and everything else in it. So just do your best estimation. That's why I don't know that it's that much better than estimated blood loss, because there's all other kind of crap in it. You need a calculator to do this in a C-section. What we have now is we have these worksheets, and Greg gets me a quantitative blood loss pretty much immediately within 10 minutes of finishing the case, which is a lot better than the 2 hours it used to take. That's why they even dropped the whole sponge thing on the scale, because it's been close enough for tar weight. They've basically measured everything and tried to get standardized sponge packs and all that so that it's standardized at every hospital. And so we can come up with these formulas so we can eliminate out, like, if you count 10 sponges, you put in there 10 sponges, you weigh them, and it's automatically subtracts the weight of the sponges and if they're wet or dry. But the problem, as you know, is they can be sloppy wet or they can be super dry if somebody's really wrung them out. So it's not perfect either, but it's not bad. We've already been through all this, so we don't need physician champions, okay? And then that basically, I'm not going to look at that, and basically they just add it up, okay? And this is what an EBR calculator looks like, not that you care, but we do have one in Cerner, by the way. The drills and simulations are very important, and that's basically, you know, they tell this horrible story here where this was driven by an actual patient, and she's a representative on the task force. So just real quick, I mean, it kind of seems obvious now, right? Melissa recalls the nurses and how they could tell how much blood loss she was losing. The nurses never weighed the blood and dumped it from the bedpan into the portable toilet. Melissa tells of feeling sheer panic when the bleeding started up again, enormous clots. I screamed, and I will never forget the look on the nurse's face. When she lifted up that blanket, I just kept thinking, God, give me more time. Give them more time. They need more time to save me. So this is the patient's thoughts, that she just saw nothing happening and she thought she was going to die. And she wound up ending up with a hysterectomy and about 12 units of blood. And when they reviewed the case, it was really came down to the delay of treatment, of not recognizing the blood loss, not quantitating the blood loss, and not being that stepwise protocol. There was just this big delay until she wound up getting a hysterectomy. And then basically a team for all seasons. We've gone through this and we're going to do the drills. And basically, this is from Kaiser, that they've learned that through debriefing, remember it's now standard, we want to debrief after every delivery, every C-section, just what went well, what didn't go well, what could we done better, and how was the communication. And remember, we do this in every case, so it shouldn't be threatening. It's not to put you on the spot. And once again, we should all be mature enough to take constructive criticism, including myself. So, you know, I just had a funny consult from Paul Stewart, and he said, you know, he thought he would consult me because he thought I was the second smartest doctor in the hospital behind him. But, you know, it raises up the point is, I mean, we're all pretty smart, but we all have room for improvement, okay? So basically, I mean, I thought that was pretty funny. He said, well, I'm the smartest doctor in the hospital, but I consider you the second smartest. So I thought that was pretty good. But anyway, it's just not a hemorrhage that we address. We're trying to make it a safer place for moms. And as you know, Bethan talks about the airline business all the time, but she's on all the state boards, the femur projects, the mortality boards. Basically, we're trying to run healthcare more like the airline industry from the standpoint repetitious, same processes over and over again to reach as close to a standardized routine, and no matter what the circumstances are. And basically what we're going to look at is how many, of course, postpartum hemorrhages we have with transfusion, and they're going to start quantitating that by looking at the number of blood products we use per 1,000 mothers, not per 1,000, well, 1,000 births essentially. Okay. Yeah, come in. So basically, that's where I'm going to end. Basically, yeah.
I just have a question.
Okay.
Did you tell the boss center that? She was in pre-op on Friday, supposed to have a tube and found out she was pregnant.
Oh, yeah, I think so. Yeah.
We didn't have a message.
Right,
Just wanted to
okay.
make sure she's on the phone.
Yeah,
Viability.
yeah.
Okay,
Thanks.
You,
Sorry. So, but anyway, just basically, blood products are expensive, hemobate's expensive, R factor 8's very, very expensive, embolization's very, 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 very expensive, and math is cheap and fewer hemorrhages that reach massive, etc. Actually, I just wanted to show you this because I thought this was pretty cool. since this is version 2 and we started implementing this downtown, and we have implemented this here years ago, about 3 years ago, by using the protocols, we've ourselves, and this should really say Indiana University Health, by the way, not Indiana University, 33% reduction in postpartum hemorrhage over 10 quarters with implementation of protocols. So that's pretty significant, a 33% reduction. And we get graded on that every quarter because I get to sit in front of our numbers. And I will let you know, we do have higher numbers than some of the other places, but we're doing a very good job because we review all those. All of those go to peer review just so we can see if we're following the protocol. And unfortunately, some of the ones that have fallen out, that's why we're doing this task force, have not followed the protocol. So once again, if you deviate from the protocol as a physician, you're allowed to do that, but make it very clear in the medical record why you deviated from the protocol. Otherwise, you're going to be considered deviating from standard practice, and that's not a place you want to delve into. Okay? Anyway, so in case you're interested, and I'll get these are online. Remember, these are all public slides, so I don't think I have to send them to you. You can just go on the website. But basically, just remember, I think this is a big telltale sign here, is something I don't do routinely. After 2 units of blood, especially in a massive transfusion, when you have hemorrhage, when you're continuing to lose blood, we got to remember about that FFP. The other thing that they didn't mention in this protocol, which I thought was interesting, is TXA. So in our protocol and in the updated protocol, they do mention TXA in their flow sheets and in the algorithms and in the flow sheets. But think of TXA early, and we do have it on the unit now, and it's in the cart because it's now lyophilized, so they can reconstitute it. So we have it on the unit at all times. So you don't have to wait that amount of time, and it's just one gram. So it's just 1 ampule basically. So you just say, give a gram of TXA. Okay, any questions? Thanks, you guys. Sorry we got a late start, so not bad, just 5 minutes over. But basically, you know, that's all that. But I had shown you, and I have all the flow sheets, and we actually have our own on the cart. I think, you know, you should take a look at it. We had talked about doing them as hang tags, but I don't know, God, you guys got so many hang tags on there. I'm surprised your badges don't like drag down on their own anyway. So you're going to have the OB hemorrhage cart. So we decided that hang tags weren't really necessary since we have a big laminated 8.5 by 11 on the chart. So, okay. Is there anything else I can answer for you guys? Got any questions? I appreciate your time.